So let's get started. Let's see, spacebar, I guess. So just basically, I don't have any conflicts of interest. And I just want to note that since this is being recorded and it will be on YouTube, for those who will listen and watch, obviously, one talk does not replace a consultation with a physician. And, you have to use your judgment as a physician in order to make the appropriate medical decisions. So the agenda today, I think it's pretty straightforward. We're going to talk about chronic illness, what that is, and it's the blueprint, the framework is, of course, insomnia type symptoms are very prevalent in patients who have chronic disease, and a lot of people also have a primary sleep disorders such as chronic insomnia disorder. But the underlying theme is what is good sleep hygiene and what is poor sleep hygiene. And we're going to identify some of the chronic illnesses that we take care of at Sinai, especially patients who suffer from, for example, chronic rhinosinusitis or COPD and asthma and other conditions. And we're going to talk about what would be the approach to improving sleep hygiene in patients who suffer from chronic disease. So the overarching theme is we try to look at things from the standpoint of first principles, like what is a chronic disease and how do we approach understanding it, and what is the benefit for the patient to understand their own disease. So some useful websites, sleepeducation.org has a lot of information on primary sleep disorders, but it also has general information on sleep hygiene and useful links internally in the website. There's a relatively new website, sleepisgoodmedicine.com. That has a little calculator in there. You could have the patient punch in some questions and it'll show them if, they have a sleep disorder they might want to see a sleep physician for. And you can actually go to aasm.org clinical resources/patient info, and that'll have pamphlets and information for patients that you can give out so that people can be better informed. Because time, of course, is limited when you're doing comprehensive preventative care and occupational medicine. And we don't always have the time to go into the sleep disorders unless you're seeing a sleep medicine physician. So the first thing I just want to do is define what is chronic illness. I think we all know kind of what it is, and the definitions vary. By the way, I have references at the end. I don't know what happened, but all of them got replaced in the footnotes, so they're all actually just bunched up at the end. But anyway, chronic illness really it is a long-lasting condition. It has usually multiple problems associated with it. It's not self-limited in its nature, and it's months to years duration. A lot of chronic diseases can be treated very well, but not always cured. And so let's focus on some of that in a little bit. And sleep hygiene should be defined. I think it's important to understand there's such a thing as good sleep hygiene and such a thing as poor sleep hygiene. And good sleep hygiene really involves, healthy and consistent practices that promote, I would say, high quality sleep and induce restful sleep. And one of the tenets of good sleep quality, no matter what the condition or problems that a person might have, is something called sleep efficiency. So if you spend a good amount of time while you're in bed asleep, the perception of your sleep quality will be better, most likely, than somebody who spends most of the time in bed not asleep, even if the total hours of sleep are greater for the person who's in bed longer. And sleep efficiency is a big tenet of good sleep quality, and sleep hygiene helps to enhance sleep efficiency. So before we go on any further, this is an important topic. Sleep medicine is an important topic, and the position of the American Academy of Sleep Medicine is always to advocate for sleep education across every level of the education system. And we actually want to promote, and in terms of policy, later start times for children, for elementary schools, junior high, high school, because uh, that affects sleep hygiene and that affects sleep efficiency, and that can delay the circadian cycle and throw it off and make it irregular. So you have to go with what is physiologically normal for your age group and understand your body even when you're healthy in order to optimize your sleep quality. So we are not able to, do 24 hours of no sleep and then crash and then sleep for 12 hours. That would not be healthy. Even if you are a healthy person without any medical problems, you want to still stick to a certain routine that is conducive to what is physiologically normal for you. And so sleep education is an important concept, even for people who are healthy, right? Especially for people who are healthy, because it is a form of prevention. So what we're trying to do is preventative medicine with the tenets of good sleep hygiene. So sleep-wake medicine, that requires an understanding of good sleep-wake hygiene. So part of the process of having good sleep hygiene is having the same bedtime every night and waking up at the same time every morning. You want to avoid wake-promoting activity for several hours, 1 to 2 hours prior to bedtime. You want to limit your caffeine intake, and you want to limit caffeinated products for up to 8 hours prior to bedtime. And normal sleep efficiency, time asleep over time in bed, is 90%. So you want to maintain a goal of 90% plus sleep efficiency. So that's really essentially what good sleep hygiene is. Poor sleep hygiene, on the other hand, that involves habits, behaviors that could negatively impact somebody's sleep quality, and it has to do with an irregular sleep routine, varying bedtimes. And I know this sounds like common sense, but when it comes to medical conditions, where you are chronically fatigued or you are in pain, it is difficult to get up out of bed and do something, to go outside and to be exposed to sunlight so that your circadian cycle is properly entrained, which can throw off your sleep-wake routine. So that's not necessarily because someone is being lazy or doing something wrong. It's because they are chronically ill, in pain, and tired. They're not able to engage themselves in the activities of the day in the morning and in the afternoon. And so they do not accumulate the appropriate sleep pressure at night in order to be able to fall asleep. A lot of other things that happen with chronic disease is patients often may move towards using electronic devices, or if there's depression, anxiety, traumatic stress disorder, distractions in the nighttime, watching TV, looking at your phone, relying on social media because of that kind of positive feedback effect of looking at something that you enjoy watching. But the exposure to the blue light, the stimulation, audio visual, that all delays sleep. And in fact, a lot of things that have to do with post-traumatic stress disorder and disorders of psychological trauma, a lot of bad stuff happens at night. For those who've been out in the field, or for those who've served, when things are supposed to be quiet, they're loud. So that contributes to trauma. And a lot of patients who go through that, whether it's physical pain or emotional pain, tend to go for distractions to help them relax and become a little calmer at night. But the stress raises your cortisol levels, which may blunt melatonin and delay sleep onset. And so behavioral techniques become very important in order to prevent or stave off delayed sleep onset and therefore insomnia symptoms. So this is all kind of related in the realm of sleep-wake hygiene, because understanding your chronic disease is going to help you understand what to do to prevent accumulation of bad habits, which would affect your sleep quality and your sleep efficiency. So we're going to try to talk about that a little bit more. And so I just have a few slides to kind of explain that a little bit more. So The first thing I want to do is I want to break down the major themes that have to do with good sleep hygiene. Hopefully, everyone could follow along. I think of this, I've been preparing for this grand rounds, for this talk. I was thinking, what are the major themes that underlie good sleep hygiene and people who might have insomnia symptoms? How do we prevent stuff? So what are the categories we could break this down to? So the first one is, even if you're not a sleep medicine physician, your primary care physicians or occupational medicine, they're extraordinarily important professions where you're the first contact for a lot of patients. Um, what is a good thing to keep in mind when you're trying to prevent problems and when it comes to sleep? So first, I would say one thing we should think about is nocturnal symptoms. So let's try to wrap our heads around the fact that we are alive 24/7. A lot of the history and presenting complaints that you ask for when you talk to patients, they have to do with their daytime symptoms. I'm going to outline some examples so that we can kind of look at this and kind of shift our perspective. Probably most of you already do this. Obviously, this is a group of experienced people. But just for the sake of completion, there's stuff that happens at night that's not primary sleep disorders that may present like insomnia symptoms, right? Because it's difficulty maintaining your sleep, which is one of the tenets, one of the categories rather of an insomnia disorder, but it might not be a primary sleep disorder. For example, here's one that's classic. You might ask patients about obstructive sleep apnea, right? And to ask them if they have awakening, gasping for air, witnessed apneas, waking up short of breath. But there's a condition where if you lay down and you're short of breath, you know, when you're supine and you're short of breath, you have to think in a patient who's chronically ill, is this paroxysmal nocturnal dyspnea? Do they have pulmonary edema? Are they edematous? You know, is this congestive heart failure, right? So you don't want to place a referral to sleep medicine that's 3 months or 4 months out, hopefully sooner. But actually, the patient is presenting to you and they might have a heart problem, and you need to address that immediately. And so, nocturnal symptoms, if they occur, that's not necessarily great, right? So you have to understand where are they coming from, and you have to rule out everything that's not primary sleep as well. So let's go down this list, and I'm going to try to go down from the top down, sort of, and kind of go through some of the conditions that present with symptoms that have symptoms that occur at night that you can be more aware of. And then we're going to like go through some of these examples in theme one in this first slide. We're going to spend some time on that. And then we're going to go into the other two themes that I kind of wrote out. So the first one we'll look at is neuro stuff, right? So people who have neurological disorders, chronic disorders, chronic disease that has to do with neuro, Parkinson's disease or Parkinsonism, alpha-synucleinopathies. We have the Alzheimer's type dementias in general. Patients at night might present with symptoms that are indicative of a neurological disorder, not necessarily a primary insomnia or something else, where there's unusual movements in the bed, there's nighttime wandering, there's unusual behaviors that predispose them to injury at night. And sleep hygiene is important when it comes to that, and I'm going to try to explain why I think that is. The other one that's neuro, nocturnal seizures, right? So we got to go back and think through the organ systems. Unusual behaviors at night where a patient might present as if they have a confusional arousal. They wake up, they look like they're awake, but they're really not quite. And there might be a postictal confusion or a discomfort. Unusual behavior at night. You have to think maybe it's not a primary sleep disorder. Maybe this is not a parasomnia per se. Maybe there's something more nefarious going on. And so we have to think about what are the other medical conditions that this patient who has had exposure to chronic exposure to chemicals, chronic exposure to carcinogens through the course of their life, ground zero, all sorts of environmental risk factors that predispose you to developing chronic disease. Waking up from a headache in the middle of the night, difficulty falling back asleep. I have difficulty falling back asleep because I have a really bad headache that wakes me up at night. It started in the past 2 months. For example, what if there's a tumor? What if there's a hypertensive emergency? What if their blood pressure is poorly controlled? So these are neurosymptoms you have to keep in mind that may present at night. Pulm, you go down the list of organ systems, you know, coughing, wheezing, all of that, shortness of breath, these could be signs of an uncontrolled obstructive lung disorder. And so, compliance with therapy, we'll go into that a little bit. That's important to consider. It may not be obstructive sleep apnea that's going on if someone is having dyspnea at night. And that's important to always keep in mind. Night sweats. We often have in our questionnaires, again, obstructive sleep apnea, diaphoresis, waking up, uncomfortable, sweating, fever, feverish type symptoms. Maybe they don't realize it, but perhaps you want to have in the back of your head B symptoms. If the patient, again, chronic environmental exposure, traveling, you're first responder, active duty, you're out abroad, you're traveling, you're in various countries. If you're having night sweats, intermittent fevers, if you had environmental exposure, you have to keep in mind, are there B symptoms going on? Another one, we're going down the list of organ, endocrine, hypoglycemia, nocturia. Yes, a middle-aged man can have benign prostatic hypertrophy, and they can have, difficulty urinating with nocturia symptoms at night. How frequent is that compared to their daytime? Is there a difference? What's their medication regimen like? Do they have nocturia because they have uncontrolled type 2 diabetes? Is there something else that's happening? So theme one is, I would say, understanding that chronic diseases have symptoms, often nefarious ones, that present at night. And that's usually not a good sign. And so you have to keep those in mind. The second theme is patient education. So first, you understand that that chronic diseases have symptoms that present at night that are not primary sleep disorders. The second one is you help the patient understand that what their chronic illness is like. If you understand your own condition, then you can move forward to improve your sleep hygiene. So let's go down the list again. For example, neuro, when you have symptoms of REM behavior disorder, when you have symptoms of sleepwalking, somnambulism, or we can say nighttime wandering, bedroom safety is a key concept. Making sure there's no excess clutter, making sure the bed is not high up off real world recommendations that have to do with actual environmental safety inside the room. I think that is actually quite important. And the environment should be structured. Let's think on that a little bit more. The environment should be structured in patients with a dementia disorder, like Alzheimer's type dementia. They might not be able to advocate for themselves and explain their history to you, or a patient with Parkinson's disease may not be able to express themselves, even though their faculties in that regard are intact, because they have those Parkinson's symptoms. Family members and caregivers are important, right? General advice, without judgment, without assumption, regarding sleep hygiene within the family. It can really help the patient. Within the group home, within the nursing home, that could really help the patient, right? Because, if there's environmental stress, if there's loud noise, if you don't keep in mind that your elderly parent or grandparent who's with you, it may be time for them to go to bed. And if the music is blasting and the TVs are on and there's light everywhere, it's not necessarily their fault that they can't fall asleep. And a disruption in the routine, we have to be mindful of the people we live with, right? this is real world, that can actually disrupt the circadian cycle, which can fragment sleep, which can then increase the risk for parasomnias and actually increase the risk for injury, right? Because patients who have neurological disorders with parasomnias, they might get hurt at night. They might have injurious nighttime behaviors and parasomnias. The same for morning, the same concept, sleep hygiene. In the morning, you want to have a structured routine where they're exposed to light, where they're able to go outside and engage in physical activity in the morning and afternoon as opposed to at night. Physical therapy appointments, group activities. If that stuff happens earlier in the day, probably would be more conducive for a good maintenance of the circadian cycle. So that's neuro. The other one is, mental health, mindfulness, meditation in the evening, stimulus control. These concepts are extraordinarily important in order to prevent insomnia symptoms. Stress delays sleep because it puts us in a state of hyperarousal, and abnormal increases in the cortisol level are associated with inflammatory marker increases. So, a pro-inflammatory state, discomfort, a decreased pain threshold. And one of the things that can be a form of secondary or even primary prevention when it comes to mental health, because life throws things at everybody, right? Nobody's immune to stressors. Our patients could be counseled on healthy sleep hygiene even when they don't have a mental health condition or a psychological condition, because having a structured routine that you more or less stick with throughout your life will help protect you from severe exacerbations of depression or anxiety, because you'll be falling back on a consistent routine that you could rely on, where you have exposure to light in the morning and a consistent RT or rise time, which is right here on this slide with the RT. So the other concept here, again, goes back to something called sleep efficiency, which I mentioned a little earlier, whereby you try to induce the perception of good sleep quality. So if I sleep for 5.5 hours, but I'm in bed for 5 hours and 50 minutes, I might be a little tired, but my perception is I made the most out of my sleep time. So I'll feel good about that. But if I sleep for 5.5 hours, but I'm trying to stay in bed for 9.5 hours, the perception of my sleep quality, in my professional opinion, I think there's a poorer perception of sleep quality if your sleep efficiency is lower, so 50%. And that's an important concept, especially for patients who have mental health conditions that they're dealing with. Chronic pain is another one. You have to pace yourself throughout the day. A lot of patients who have fibromyalgia or arthritis may not move as much because they are in pain. So it's important to counsel on the importance of movement and graded exercise, especially towards the morning and afternoon times, because if you do not move, you will not spend your energy and you will have decreased sleep pressure at night, and you will not feel as sleepy, even though you are tired and in pain. This is just common sense. And so that, of course, helps to entrain your circadian cycle to prevent insomnia symptoms at night. The next one I want to just talk about a little bit is cardio. So patients who have, coronary artery disease or angina, a lot of patients might have chronic fatigue during the day. People with heart disease feel tired. They feel fatigued. So they might reach for the cup of coffee because they feel fatigued. But they might have coronary artery disease. They might not be perfusing their heart. They got their 7 hours of sleep, but their cholesterol's abnormal. They're at risk. Their calcium score is 500 or 1,000. And what actually they're doing when they're reaching for that cup of coffee, they're trying to feel better with their energy, but they actually have a heart condition. So you have to see what's going on. Make sure that patients are assessed for coronary artery disease. There are appropriate ordering of the lipid panel of the CAC. And chest pain, in my opinion, is never okay. It's never good to have any form. I never like any chest pain, is what I will say. So that always should be taken seriously. The next one is endocrine. frequent awakenings at night, diaphoresis, feeling uncomfortable, feeling a little bit lightheaded. One thing that might be extraordinarily helpful for patients who suffer from type 2 and type 1 diabetes is glucose monitoring. And so continuous glucose monitoring, maybe a balanced nighttime HS, nighttime snack, can help stave off hypoglycemic episodes at night. So you don't want to have a large meal at bedtime. You don't want to drink a bunch of water at bedtime because you're going to have, nocturia. It's going to delay your sleep. You might have acid reflux and exacerbate those problems. But what you do want to have, which is basically the concept for all of these when it comes to patient education, is you want to have a structured approach to your day. And you have to understand what is the chronic problem that I have and how do I deal with it from the standpoint of good sleep hygiene. We could say good sleep wake hygiene. And so the first concept again was for us to understand how chronic diseases can present at night, right? And the second one was how to help the patient understand their chronic illness and what preventive measures they can implement to take care of their condition and prevent problems. And you throw into that sleep, not just wake, not just daytime stuff and medications when you take them in the daytime, but also sleep hygiene. All right. So now let's go up to the third theme, which is sleep efficiency. And I talked about this a little bit. Again, total time of sleep should be 90% of the total time spent in the bed. And the example I gave earlier, I won't repeat. But what I would tell you is what I advise patients when appropriate is that behavior is important. Our approach to things, how we do things, because a medication like a hypnotic, it might affect 1 or 2 molecules in the brain, right? Let's just say that in lay terms. And there might be some association with side effects with the use of a hypnotic, especially chronic use, especially for older patients with a lot of these hypnotics are on the Beers criteria, which we are all familiar with. But your behavior and how you move through your day, right? And what your routine is, that affects your entire brain and all of the neurotransmitters simultaneously in the right way. And so that's why it's so important to have good sleep hygiene. It's because waking up at the same time every morning, going outside, doing a little bit of exercise. It sounds like common sense, but all of your brain is influenced by that. Whereas taking a medication works on 1 or 2 parts of your brain. And so consistency is really prevention. Consistency is prevention. It's preventative medicine. Something that can help patients get a sense of where they're at with their sleep, which is a fairly benign exercise. And I actually like this better than wearables in a lot of cases because the patient, when they use a wearable, they're wearing it on their wrist or they're wearing something that's telling them how much they slept. So, okay, you can get that information from a sleep study or from an actigraph, right? It's telling your patient how much they have slept, 5 hours per night. Your sleep quality was poor. You're not getting enough deep sleep. You're not getting enough REM sleep, right? Some of your patients might come to the clinic and they might to show you a graph. Should I see the sleep doctor? My wearable is showing all of this information. It looks like I'm not getting good sleep. But what's better, in my opinion, in a lot of cases, let's not be, absolute here, but in a lot of cases, a sleep diary. Because the patient is writing down how much they slept. The patient is writing down what their sleep quality felt like. Right? So your perception of your sleep quality is extraordinarily important to the point that the International Classification of Sleep Disorders 3 text revision 2023 edition and previous editions include perception of poor sleep. Your poor relationship with your sleep quality is a criteria for chronic insomnia disorder. If you sleep 6 hours a night, but you've never even thought about it and you feel incredible, Maybe you actually sleep 7 hours a night, but you think you sleep 6. That doesn't necessarily mean the patient has chronic insomnia disorder. They haven't yet met all the criteria, right? They could just have short sleep time. But if you feel like you're not getting enough sleep and you feel like your sleep quality is quite poor, your perception of sleep. So maybe an actigraph is helpful. Maybe a wearable can provide you with that information so that you can see what's going on. And sometimes they're extraordinarily helpful. They can show you their heart rate. They can show you a little bit about heart rhythm. But from the context of your own perception of sleep, I don't know if it's great for something else to tell you every day and remind you of how bad you're sleeping. Maybe it's better that you just have a discussion about preventative techniques and good sleep hygiene. And if you do think you have a problem, you write it out on a sleep diary, and then you bring it back to your physician and you review it. Because that exercise is really helpful. You're taking ownership. Something else is not telling you what's going on. You're putting it on paper so that you can take a look at things after 2 weeks and see what you might want to address. So I do like the concept of a 2-week handwritten or typed out sleep diary that a patient provides us with feedback. And there are other questionnaires that exist that I don't think we implement enough in primary care or in sleep medicine that help us to assess a patient. The Epworth Sleepiness Scale, the Insomnia Severity Index, the Stop Bang Questionnaire to screen for sleep apnea, the MECSF assessment, CFS assessment that checks for chronic fatigue syndrome or systemic exertion intolerance disease. So a lot of our patients are first responders and worked at ground zero and also, just were there. And so there's a strong association in those patients with chronic rhinosinusitis, post-traumatic stress disorder, and some of the wonderful professors that are in this chat have done amazing research work that looked at the patient population within the WTC program. And, Mount Sinai takes care of those patients, and all of the health systems are involved, I believe, in some way in New York City. We know that patients really can suffer a lot from chronic rhinosinusitis, and that can really impact your sleep quality, even independently from a primary sleep disorder, even independently from obstructive sleep apnea. The nasal passages are blocked, chronic nasal congestion, and that can lead to disturbed sleep because of postnasal drip. You might wake up with a cough. Waking up in the middle of the night, it doesn't mean there's a primary insomnia or there's an obstructive sleep apnea. You can have postnasal drip from chronic rhinosinusitis. And it goes back to the point again of consistency and routine. Having an outlined routine, maybe even with little alarm clock reminders, that before bed, you have to do your nasal regimen. Maybe it involves just saline rinses, sterile saline rinses, and that's sufficient. Maybe you also need to do low-dose corticosteroid nasal spray or a dual-action nasal spray, or even take a medication. But consistency and routine, it might help prevent the need for surgical intervention for a lot of nasal obstruction symptoms, or lead you down the path where maybe that's really, by addressing the CRS, you feel a little better. Consistency and routine, I think, also helps people who might be suffering from traumatic psychological conditions. And there are some things that you can reassure patients about, where a lot of people with PTSD might have sleep paralysis symptoms. On its own merit, a sleep paralysis episode is a fairly benign condition. They're common, so you can use it as a piece of history to help you with your diagnosis and with your treatment recommendations. But essentially, what parasomnias and what sleep paralysis responds to really quite well is the consistent sleep routine and making sure you have a healthy sleep efficiency, because then you're going to have higher chance of having your sleep cycles, stage 1, stage 2, deep sleep, and then REM sleep, by having a better sleep efficiency and consolidated sleep. If you're able to consolidate your sleep, you probably will have less parasomnia episodes. The other group of patients that can suffer from sleep disturbances are patients who have chronic fatigue syndrome, patients also with long COVID and other chronic disorders like it, there could be disturbances in the sleep-wake mechanism. And with ME/CFS, we know from the Institute of Medicine criteria, it is a disorder of neurologic, immune, and metabolic disturbances. And so stress is a major component. If there's underlying stress, underlying generalized anxiety, anxiousness or environmental stressors, it can impact, chronic stress can impact your immune system. It can affect your circadian cycle. One of the symptoms that is, I would say, near pathognomonic for ME/CFS is something called post-exertional malaise, where even days later after exercise, a patient may feel quite out of it and have a prolonged recovery period. There's a gradient and a spectrum to how severe it is, but pacing is a treatment option for that that's recommended, which is a balanced approach to activity between periods of rest. Or you could say the other way, which is, a lot of people with ME/CFS require rest throughout their day, and their family members should be understanding of what it is that's going on, and they're not doing anything wrong or heaven forbid being lazy. It is chronic fatigue. It's difficult to move, but it's important to have graded and a balanced approach to activity. Get up and sit in a chair. Try and go for a light walk, but don't over-exercise, and don't forget that with ME/CFS, that can create more disturbances if you overexert yourself. And so pacing is extraordinarily important, and actually it comes important because of good sleep hygiene. If you're able to pace yourself, you're able to expend energy in a safe way throughout the day. You're able to accumulate sleep pressure and be able to fall asleep a little bit easier at night. And that's an important strategy in order to prevent insomnia symptoms or sleep disturbances at night. All right. So let's talk a little bit more about sleep-wake regulation. I'm just going to mention a little bit about that right now. The circadian cycle, really it's regulated with interaction with the external environment. The word for that is entrainment, E-N-T-R-A, entrainment. Light goes through the retinothalamic tract, and that enhances melatonin release from the pineal gland, goes through the blood-brain barrier, which then stimulates the hypothalamus to induce the processes of sleep. Light, pineal gland, hypothalamus again, neurotransmission occurs, processes for sleep. So light therapy can help provide you with a sense of energy and wakefulness and reduce symptoms of several mood conditions, such as seasonal affective disorder. In the morning, a light therapy lamp, 5,000 to 10,000 lux, LUX, for about a half hour during the winter months can help improve mood in the appropriate case, your decision as the physician. And also light reduces the release of melatonin, and darkness is the one that stimulates that. The other thing that increases melatonin, release is it occurs when cortisol decreases. So at night, it's a temporal relationship between cortisol and melatonin, which is, sent out from the adrenal glands. Cortisol down, melatonin up. In the morning, melatonin down, cortisol up. So that's essentially the things that I wanted to kind of focus on. There's probably 20 to 30 common chronic diseases that we come across in occupational and primary medicine and just throughout. And depending on the definitions you go by, it's really defined as something that's going on for over 12 months. Treatable, but not quite curable for a lot of conditions, but very much treatable. And the tenets I want to go back to are theme 1, know your illness and how it presents, that you're taking care of for your patient, and how it presents at night. Theme 2, educate your patient on what that illness is like, what it is that they have, so they have an understanding and insight, not just here's the metformin, goodbye, but let's talk about diabetes a little bit. Let's set up an appointment so that we can understand your health status, Where are things at for you? What are the top conditions, chronic conditions? How do they affect your sleep? And that's theme two. And theme three is the relationship with sleep. What is the sleep efficiency? Are you consistent with your routine? Are there environmental or outside factors that might affect your sleep? And then you can focus on that. And often, especially with patients who have neurologic conditions or may not be able to advocate for themselves, general, non-assumptive, non-judgmental advice about bedroom safety, about an environment that's conducive more for sleep, especially when patients present from the nursing home or a caregiver comes over with the patient and you're talking with the nursing staff, et cetera. What is that environment like? What is the schedule? What is the schedule in the group home? What is the schedule? What time do they get up? What time do they go to bed? And the American Academy of Sleep Medicine now has a very simple question that they think physicians should ask it at a checkup, like not necessarily an acute visit, but when you come in for your physical. How is your sleep? Simply, you ask, how is your sleep? The other thing I want to point out is, there's like 18, 19 slides on here. You didn't really see a lot of stuff on medication, right? Because there's all of this other stuff you can do. Please note, before you go down the path of hypnotics. Number one, is a medical problem the reason why they're having a sleep issue? That's number one. And so that's really kind of my point. I think we all are aware of it, but just for the sake of discussion. So this summarizes what we discussed. At the end of the day, a lot of people, maybe even the vast majority, would benefit from cognitive behavioral therapy for insomnia. That has the best outcomes long term. Often, you might need to use a combination of pharmacotherapy, but you got to rule out the first stuff first. And I just want to put a slide on here, what I think the future might look like for sleep. And I just want to take a moment to talk about that briefly. I think that in the next 5 years, we're going to have generative AI help us summarize and also score sleep studies, right? Just like radiology gets that done and they sign off. Virtually all radiologic imaging nowadays is impacted by AI in some way. But more than that, I want to make a point on this just a little bit. If you have a patient who had a sleep study, let's say 23 years ago in 2001, and it showed obstructive sleep apnea, what is one thing, if you can remember from the sleep reports that are sent, not just within the system, but outside the system, it's the apnea-hypopnea index that's reported. And there's other metrics. There's lots of different tables and stuff on the sleep studies often. But what is not really discussed very often is within each sleep apnea episode, how much and for how long is the desaturation? So you can have an apnea-hypopnea index of 5, but the desaturations might be quite deep, or there might be an underlying hypoxemia, right? And then after weight loss, you can still have an AHI of maybe a 4 or 5, technically mild sleep apnea, right? But there's no more hypoxemia, or because something was addressed, or the desaturations are a little bit more mild. So the hypoxic burden and the quality of the respiratory events, that's one thing we'll be able to provide more data on and trend, which would maybe AI will help summarize for us when it looks at all the different sleep studies within the chart and summarizes them for us. Not just the AHI, other things too. The electromyography data, the electroencephalography data, the amount of sleep spindles per cycle on average, the amount of K complexes, and the muscle tone, if it's abnormally increased compared to, in the past, if there's a change in the muscle tone during non-REM and REM sleep, if there's fragmentary myoclonus during a sleep study that's increased in nature and now it's excessive, and how that has changed. The generative AI will help us to actually look at that and provide a more thorough and concise report that trends things, especially when it comes to polysomnography data. The other one that I think is going to come along soon is augmented digital cognitive behavioral therapy, where it's not just an app where you put in, what time you go to bed, when you wake up, and it gives you some basic advice, but it actually guides you and maybe even be linked with your EMR, with your patient record, so that it can help you adjust with the guidance of your doctor exactly what I was talking about earlier today, which is knowing your medical conditions, knowing the medications that you're taking, and how do you need to adjust them in order to prevent sleep issues from arising. And so that's essentially my talk. Thanks so much for listening.